I'm Ed Salek, and the show is in honor of, and we got a blockbuster for you today. We're going to go through a lot of things that mean a lot of valuable information for all of the veterans and their families that are out there. So you just stay tuned. Don't change the channel. And as always, my co-host Paul Dietrich is here, and Paul is responsible for putting most of the shows together that we do. I want to take time at the beginning of the show, though, to thank my crew, because they're always here and they're always doing a great job. Rosemary in the control room, she directs and she edits, and she's got to be the best editor and director that I ever met in my life. JR on camera, Mark on camera, and Roman in there on audio. Thank you very much, guys. It's much appreciated. Now to today's show. We have a special guest here, Dr. Ayse Aytaman.
I got perfect.
I got close anyway.
Thank you.
Dr. Aytaman's been with us before on a couple of occasions, and she always brings great information. Dr. Aytaman, you were recently elected the governor of Brooklyn.
I am the governor of American College of Gastroenterology, but I am foremost the VA.
Right.
I chaired the liver team of the VISN 2, Veterans Integrated Network 2, which is basically from Albany to Atlantic City, and I'm the chief of GI and hepatology at the VA New York Harbor, Brooklyn.
That's great. Now, you were Physician of the Year honoree by the New York Greater Chapter of the American Liver Foundation, am I correct? Congratulations,
yes,
that's a very great honor.
They did that, and I think this was never given to a VA physician before, and I might be the first female also.
Congratulations on both of those issues. Now, what I'd like you to do for us, if you would, is introduce us to the guests that you brought with you today.
Actually, I have two guests for you, and I am incredibly honored. I mean, Dr. Wolkin is an incredibly accomplished psychiatrist. He is the vice chair of the NYU, as well as he has been our associate chief of staff for mental health for the VA New York Harbor since 1998, correct?
Correct.
And he has done a tremendous amount of research, has been co-PI, PI of multiple VA cooperative studies, looking at the imaging for schizophrenia, other mental health disorders. He has worked on post-traumatic stress disorder and in the evaluation of prevention of suicide. So everything that's incredibly relevant to our veterans nowadays. And he just set up a multi-million-dollar telemental health program. I'm sure we are going to hear about that today also. And I am incredibly impressed by the plethora of the programs that's being offered under his leadership.
Welcome.
Thank you very much.
The next guest I have is Eric Nelson, who happens to be my medical student from SUNY downstate. He's also a Yale undergrad, but most importantly, he is an Iraq and Afghanistan war veteran. And we are going to listen to his stories from the veteran's point of view. And he is now becoming on both sides of the field.
Absolutely,
right?
Good.
Soon to be a physician within a year and a veteran.
Very good. Welcome also.
Thank you.
Let me just say this before we get into it, but in my 6 years of doing this program with Paul, I've seen a remarkable response from the veteran community, and we hear nothing but good things that they talk about. When they talk about the VA, especially in the New York area, we hear nothing but good things from the veterans about what's going on with the VA and how they are being treated and how the help is readily available there. Paul, can you chime in on that?
The only negative that I heard, and I've heard this from several of my female members, is that they continue to be addressed as dependents when they come in. And again, this is a cultural change for people not realizing that females could be just as much a combat veteran or a veteran as males. That is the only negative that I've heard from all of the veterans that I deal with every day.
And I think we addressed that issue the last time, and we are really working very hard to change that.
Well, once again, as Paul said, that's a cultural thing, and it has to do with the worker that's at the reception desk and on the telephone or what have you, and they have to be
sensitized,
educated into.
Absolutely, that's very correct, and we have to change all our mindset towards that, because we have really a huge female workforce now in the military, the largest growing
17%.
group. Exactly.
17% is female currently, and you have to give due respect for that.
Absolutely.
And they are out there in combat, and so.
And we have done specifically a show with several of our women veterans just recently. I believe it was in March, and again it was so that the general populace can see that not all veterans are male, and they come in all shapes, sizes, and colors, and they're all still veterans. So that's the important
Absolutely.
part.
But,
Doctor, can you give us any updates on hepatitis C and liver disease?
You know that's my favorite area. Having said that, in the VA, it's very difficult to find someone with Hep C anymore, because we treated them all. So we have completed the 100,000 veteran treated mark in the end of December. And we are now reaching over 90,000 cured mark. And we have very few veterans left to treat, somewhere around 30,000. And those are very tough to treat patients.
One area that Dr. Aytaman has really been pioneering in has been the identification, pursuit, and treatment of patients with substance abuse disorders who also have hepatitis C, who are also often otherwise left out of those treatment protocols. And Dr. Aytaman has been really tireless in terms of opening up the treatment for all of the veterans, including those with substance abuse who otherwise typically aren't brought into the fold. And that's, from our perception in mental health, been a tremendous recognition of some of the stigma that's faced by patients with mental health who have actual other medical treatment needs.
Well, what I would note here is, if you watch television nowadays, there's a great amount of interest that's being given to Hep C.
Yes.
And to the general populace, okay? And it appears to me that the VA is 10 steps ahead of the...
Way ahead. Actually, we are recognized not only nationally, but internationally as a leader in population health management what concerns Hep C. What we did in the VA system for Hep C is unprecedented. No other healthcare system can come close. And what we are now seeing with those huge numbers is 100,000 treated. We are now looking at the natural history on the long term, its impact now. Yeah. We have now in the VA liver cancer incidence declining. We are seeing it visibly. But not only liver cancer, what we are realizing now is hepatitis C is associated with increased cancer risk of all cancers. And we are seeing overall mortality declining, overall cancer rates declining in these patients, which is mind-boggling. We are starting to publish, and virtually every other month there is a major VA publication with huge numbers showcasing these things. So we are going to see that further. Now we are moving to advanced liver disease related to obesity, diabetes, which is the next menace for us. We are moving our very well established hepatitis C teams now towards that. Hep C in the VA is a little bit past, you know. Yeah. It's starting in the general population, but our screening rates for hepatitis C in our facility is 93.6%. The remaining veterans are either not using the VA system or have moved otherwise and very difficult to reach. And this is all across the board. So way ahead of the industry.
You are a genuine heroine amongst the veteran community, and I could tell you, the members that I speak to...
I happen to be at the right place during the right time.
Well, they speak all very highly of you.
And you did the correct thing. That's also important.
Yeah. Eric, we haven't had to even hear you speak yet, so we're going to... Could you tell us a little bit about your deployment history, where you were in the service, your education?
Yeah, I was in, graduated from college, joined the Army, went through basic training, and then I went through officer candidate school. I was based in Italy, which was really nice, for a little while, and then we got deployed to Afghanistan. That was my first combat deployment. And it was a really tough but rewarding 15 months. Some of the best friends I have, and some of the most challenging and experiences of growth. And I returned. I was planning to leave the military, but the military had other plans for me. We say I got voluntold, as happens sometimes for another deployment. But that, again, I went to Iraq. I was an infantry company commander during the time of the surge. And some of the American people, this is how I felt at the time, had a sort of we broke it, we bought it attitude towards Iraq. And it was to be part of the team there. I got to meet General David Petraeus a few times. I think he had a great plan. Seeing it turn from a war zone, the area I was in the Triangle of Death, to
That was a horrible area.
Horrible area, to a place our colonel would always say, safer than the streets of Chicago.
Yes.
I always feel bad for Chicago when he would make that comparison.
But it's true.
But it was true. And kids going to school. So that felt special to be a part of that. And everybody, we all came back in one piece from both deployments. So that was also, there's probably a little bit of a lot of luck involved in that.
Okay.
I often point out one item. I was there for before the surge and then through the surge.
Yeah.
And the second year, which was after the surge had pretty much taken effect, I was able to run a 5K in downtown Ramadi. Now, the year before, you didn't even want to get off the plane in Ramadi. You wanted to stay on and fly by. There were incidents every day in downtown Ramadi. People were getting killed, innocent locals, soldiers.
Yeah.
It was a terrible place. And a year later, it was safer than running in downtown Manhattan. It really was. And you didn't have to go out wearing your body armor any longer. You didn't have to carry a weapon. It was totally changed. And to me, it was just amazing that big of a change could happen in that short of a period of time. Unfortunately, I don't think we sustained that change, but that's a different political story. The actual change did occur, and it was throughout every place in Iraq. So.
And you think it rolled back afterwards?
I do believe that it has rolled back somewhat, and I use the analogy that when you're changing people's minds, it takes years, and you can't just declare that you won and leave. And look at, we still have troops in Europe, we still have troops in Japan, we still have troops in South Korea, because you've got to change the minds of people going forward. And
Well, Eric, tell us, you did 2 combat missions, and now you're in medical school. What are your experiences with the VA?
Well, I at first went to the VA just for health care. I'm a student, so I didn't want to pay for health care. It was free through the VA. Why not go there? And while I was getting my yearly checkups to work in a hospital, you have to have certain tests done, and just for my own health, my primary care doctor insisted that I go see a mental health counselor. And I don't have PTSD. I don't think I, sort of compared to others, went through any particularly traumatic experiences. But I went, and he was just a very skilled mental health counselor. He spoke with me for an hour. We talked about some of the difficult experiences I had been through, losing friends, and I came out feeling that a great weight had been lifted off of my shoulder. It was and I also felt sad that some of my friends who aren't here with us today didn't have that same opportunity. I mentioned I came back from both deployments where we didn't lose a single guy from my, they were all men at the time in the units I was in from my platoon or company. But a very close friend of mine from my platoon who I stayed in touch with committed suicide a few years ago, and nobody had seen it coming. And I just feel like if he had gotten into that office to speak with that person I had, he'd still be here with us today.
And this goes back to what I've said before, and as I mentioned, I lobby for trying to improve veterans' lives. When I got out in 2008 through Fort Bragg, there was no requirement that I meet with anybody. There was no requirement that I meet with a doctor. There was, basically, they wanted me off the payroll roster. Turn your stuff in and get out of here, Dietrich. That was really the philosophy. And I wonder how many people we're putting back into society after some pretty strenuous combat, not realizing how injured mentally they are. And hey, we have 20 a day committing suicide.
Yeah.
Why? Because I think because they're not getting the help they need, they're not being forced to at least meet with somebody to at least talk about this.
The statistics bear that out. Of those 20 a day, 14 are not in treatment with VA. Only 6 out of the 20 are. So
yes.
That's our challenge.
And I really think it's got to be forced, because at that point of your life, all you want to do is get out. All I wanted to do was be gone from Fort Bragg. I've been on active duty for 2 years, in combat for 2 years. All I wanted to do was go back to my life. But maybe you need to be sat down and forced to do.
We all left the military. I don't know, I left back in Vietnam days, but with the image in my mind that I'm going to live my own life and I'm not going to do this anymore. And I'm a big boy. I can handle that problem. I can handle any problem. And I saw combat, so you come out with that attitude, and you couldn't be further from wrong.
I agree. People don't know that they need help until it's too late.
Until they get into problems with the law, or they get in problems with just society in general. And I mean, I've talked about my experiences before. Come home on leave, and I'm driving down to see my daughter in Washington, D.C., and my blood pressure's up, my heart rate is up, because I'm driving down the street without concrete walls on either side of me.
Yeah.
And I'm sorry, but if you've been in combat in Iraq or Afghanistan, there are concrete walls every place. And you feel you still are in combat. I honestly remember, where's my pistol?
Yeah.
Feeling for it, because you've worn this for 2 years. These are all symptoms of having been in that kind of situation. And hey, yes, I think I've been able to get by them, but I'm still nervous driving down certain roads, and probably will be forever.
Doctor, can you tell us a little bit about the VA health team in New York Harbor?
Certainly. So VA New York Harbor is a healthcare system that includes several facilities. We have medical centers in Manhattan and Brooklyn, and of course the what we call CBOC, the community-based outpatient clinic here in Staten Island, as well as in Harlem. And at all of those sites, we have mental health clinicians providing care. We have more intensive and a wider array of mental health programs at the 2 medical centers, but across those 4 facilities, we provide a comprehensive program for treating a wide gamut of mental health disorders with people who have expertise in those specific areas.
Oh, do this?
Do you have a separate team for PTSD? And can you tell us how you've been approaching this with both the older veterans? Because I can tell you that in my post, I have World War II veterans that were never diagnosed, and maybe 3 or 4 years ago, they started going for treatment. I have a fellow from the Korean War, same type of thing. 50 years later, he's finally diagnosed with PTSD, been living with this for all of those years. And those people, in my experience, are somewhat likely to commit suicide because of that, having bottled that up for all those years.
So VA has, over the years, become increasingly aware of the issues that you've mentioned and taken a variety of steps to be more proactive, not only just in providing treatment, but in terms of screening. So to your first question, we have what are called in the VA PTSD Clinical Treatment Team, PCT, and we have a PCT at the Brooklyn campus and one at the New York campus, comprised of approximately 5 or 6 mental health clinicians, interdisciplinary, including psychologists, psychiatrists, social workers, nurse practitioners, who have expertise in a wide modality, a range of modalities of treatment. So we have those 2 teams in place. Between them, we have approximately 1,200 veterans who are seeking and who are receiving active treatment for PTSD. The general approach, you mentioned older veterans and younger veterans, and certainly there are differences in terms of their experiences, in terms of where they are in life and their current needs, and also consequences of, in some cases, having endured PTSD for many years, and for others it being more recent, so that the memories, the trauma may be more recent or less recent. So the approach that we try to emphasize is, one, to customize treatment to the specific need of that veteran, whether it could be age in terms of how many years since they had their combat experience, just chronological age, but also gender and other specific issues. So by customizing treatment on an individual basis, try to optimize how we're addressing their specific issues. If it's a younger veteran who's more focused on returning to employment, we'll emphasize that. For the older veterans, they're not looking at that, they're looking more at retirement. So we also have cohort groups who will have combat era groups, so there could be unfortunately, increasingly less of a World War II group, but certainly Korean, Vietnam vet groups, women's groups. So again, trying to put them in a situation where they feel that their specific issues are being addressed, and they're comfortable. And they're comfortable with peers that they can best relate to.
Excellent.
And it's not in the question. I just thinking to myself as you were speaking. Let's say my son sees me as a 70-year-old plus with combat experience, and my son is now 45, 50 years old, and he sees that maybe I need to talk to somebody and to get help. How would he go about doing that within the VA?
So there are a variety of entry points that someone who has a relative that they can bring to our attention. And the most severe and acute situation, if it's a crisis, of course, they can call the Veterans Crisis Line. We get so-called third-party calls who are alerting the crisis line to concern about some significant other. So in an acute situation, that would be the most immediate remedy. For New York Harbor, we have on our intranet website, on the front page, a portal that, do you have a question about getting help for mental health treatment? If they click on that portal, it sends an email to me, they'll get a response within 48 hours. They can call our clinics and ask to speak to someone and get advice on how to, ultimately, of course, the veteran has to come in, him or herself, but how to help motivate someone to do that. And I think that's that extra emphasis and to use the word leverage from a family member can sometimes be the difference maker in terms of inducing someone to come in who is otherwise, for a variety of reasons, less inclined to do so.
One of the things we always do on this program is we address the family members and we say, if you see a problem, something's not right, whether that veteran be from Afghanistan, Iraq, or Desert Storm, or even Vietnam, we try and alert them that you can do something to get them in the right direction, absolutely, because they probably won't do it for themselves,
but for the family member.
And especially for the guys that from Vietnam, because if they haven't done it by now, they're going to need somebody to kind of prod them along to get it done.
And buddies and peers as well.
Yeah.
How about the situation with opioids? Do you have programs specifically for opioids? And I can tell you that I'm a mentor here at the Veterans Court on Staten Island. I see drug use, alcohol misuse quite often as underlying. And also again, going back to what I said before, almost every one of these, just me talking to them and not being an expert on PTSD or damage to the brain, almost everyone I talk to has some symptoms to me of PTSD and some symptoms of traumatic brain injury. And I'm saying, what's the commonality here? Mm-hmm. But a lot of them misusing opioids in particular. So could you talk about that and what the VA is doing?
Sure. So there's no question that the country as a whole is being really ravaged by this opioid epidemic, which is in every sense an epidemic. VA has really taken a lead and very aggressive stance in terms of trying to address the opioid epidemic in a variety of respects. Certainly in terms of looking at areas where there is risk, so patients who are treated for chronic pain, reevaluating what the treatment parameters are, looking for medications that in combination with opiates are dangerous. In our area in mental health, of course, our particular focus is on treating the underlying disorder, particularly if it's opiate use disorder, and bringing to bear the full armamentarium of treatments that are available. So we have been very actively promoting those programs. We have a robust substance abuse program, and particularly focusing on opiate use at both of the campuses. Just the other day, we had an event in our lobby promoting both suicide prevention and the opiate epidemic awareness by handing out gun locks. We gave out 200 gun locks, and we gave out 150 Narcan kits, which are the rescue kits. So a family member can have the Narcan kit, so heaven forbid something horrible happens at home, the family member can be responsible for that rescue.
It's a very good thing.
So we're very aggressive at that. But in particular, the mainstay is medication-assisted treatment, and we've been pushing for increased availability of that through both primary care, because sometimes being in a substance abuse program or mental health program is stigmatizing. So just to get that even from your primary care provider, that medication treatment can be a more acceptable venue in which to receive treatment. So we've been developing that, as well as, of course, in our core mental health programs.
I know that Eric had also a friend who actually ended up with alcohol and drugs, and probably there was some PTSD underlying there.
Yeah, he had been what we call blown up a few times. There's a hallmark of the modern conflict. Conflicts is IEDs, improvised explosive devices, roadside bombs. And we always wondered if what this particular buddy of mine that you mentioned, if part of one of his risk factors is that he had been in 2 such attacks. We got back, I had lost track of him, and when I had heard that he had passed away, and I looked up his story and heard from a few other people who had stayed in better touch with him, he started getting into alcohol and drugs and trouble with the police, and that all led to his demise. And it's this is somebody who was just one of the most solid members of our company. I think he's one of the big reasons that we all came back in one piece. But again, seeing what happened to him afterwards, it sort of spoiled that initial joy that I think we all felt, or relief of not having lost anyone.
There's an important issue here from perspective of treatment. For many years, there was the notion, well, if you have PTSD and substance abuse, which is, as we've alluded to, not an unusual combination, it's a common comorbidity, you can't treat the PTSD until you treat the substance abuse. So all the patients that had PTSD were under the notion, well, or were being told, first let's treat your substance abuse while the PTSD symptoms continue to torture them. The more current thinking is, no, we treat both concurrently. How are you going to solve substance abuse while someone is still suffering from all the symptoms of PTSD? So again, that's a relative recent development that's been borne out in scientific studies, that the combination, the concurrent treatment of both is effective, and a lot of that research has come out from VA, and it's reflected in the fact that our PTSD teams, both teams have what's called a PTSD SUD, substance use disorder specialist, someone who has expertise in both disorders. So we really try to look for that and hone in on those comorbidities, particularly substance abuse, for treating both elements simultaneously.
I have a question in regard to that. I think VA has gone a step forward, and the people who have gone into alcohol and drugs while they were in military and got dishonorable discharges, we are now looking at them differently and trying to give them VA mental health benefits. Am I on the right track?
The Other Than Honorable Discharge initiative has really been a far-sighted idea to really bring back veterans who get into the politics of it, but for one reason or another are not eligible for VA care, and it could be the perception that had been dishonorable behavior had been misinterpreted. Really, that was the consequence of disorders that they were suffering as a result of their experience in the military, and they're now eligible for care within a period of time, come into the VA and have access to mental health care, and our staff are very aware of that initiative, and we have a point of care coordinator for that. So that's a very active initiative at the present time.
There is also a program to get those people reevaluated for upgrading their discharges, and that's again a very important, very important item. I think we have to separate people that are wounded from people that just choose to do this for whatever reasons. And I don't think in the past that was done. I know as a commander, I would end up with somewhere around 3 to 5 every month who were coming up hot on some drug. This is back 2006 time period. And administratively, we were processing people out of the military back in my time as a commander. And that's different than they were suffering from something and and then having this as a secondary, almost a secondary type
that's
of
a challenge.
effect.
PTSD is the invisible wound, so it's not apparent.
Invisible wound.
And
That's
then
true.
somebody's life is ruined forever because of that. That will follow you. So, I had talked a little bit about the mentoring, but I know that there are programs out there, both inpatient and outpatient, for substance abuse. Could you talk a little bit about those and how they interrelate?
So the successful treatment for substance use disorders in general requires having availability of an entire continuum from the time someone comes in and says, I have a problem and may need detoxification, to ongoing treatment, residential rehabilitation, and even continued check-ins and follow-up during periods of abstinence. So one of the more, in other sectors, areas that's typically harder to access would be that intermediate period of residential care. We are very pleased that we have several residential programs in New York Harbor for substance abuse. We have what we call an early stabilization period. That's a residential program, 21 days, to help stabilize patients following detoxification and begin to plan their recovery period. We also have a psychiatric or psychosocial resident, it's a mouthful, PRRTP, a psychosocial residential rehabilitation treatment program, which recently moved from our St. Albans campus to the Brooklyn facility so that they would have better access to both medical and mental health treatment. And that provides up to 4 months, or it's individualized, but can be up to 4 months of treatment, particularly to address substance abuse disorders. And that period is really critical of keeping them in an environment away from people, places, and things that
will lead them back
into drugs. So that somewhat cloistered environment, yet one where there's active treatment, is a real critical ingredient in long-term successful recovery.
I had a question about PTSD. Does there have to be a traumatic combat-related incident to trigger PTSD, or could somebody just be in the service and on board a ship for 2 years and leave with PTSD?
So PTSD, by definition, is a post-traumatic disorder. Right. It can certainly happen in civilians, and it's well recognized that there are many types of trauma outside of combat exposure. Within the military, we typically focus on combat exposure, but trauma is somewhat dependent on how it's perceived by the individual. So, for example, perhaps being on some exposure just to body bags, to seeing, so without having even been in combat, but just the horror and the thought of the process of bringing home dead military can be very traumatic. So what constitutes trauma can be quite variable, and I think it's important to not have preset notions, what could be your trauma and what could not be, and to listen to a veteran and understand how for that person that was particularly traumatic.
And the reason I ask, I have a friend whose son came to me and said, I think he's got that PTSD thing, you know, we talked to, he says, but he never saw any action. And hence the question.
There can be automobile accidents, that's a source of PTSD in civilian life. That certainly happens in the military as well. I mean, just the fact that there's PTSD in civilian life means that there are plenty of traumas that, in the course of everyday experience, one can come across, and the military is certainly not immune from that.
How are you reaching out to the younger veterans? And this is an item of specific interest to me, because I can tell you that the organizations, the veterans organizations, have difficulty relating to younger veterans. They're just don't seem to want to join those organizations. And I think it's a shame, because there's so much that the older veterans can help them with.
I'm so sorry that Yvette Branson couldn't be here. I think this is also one of Dr. Wolkin's initiatives, but she's one of our psychologists who runs this vital program, Veterans Integration to Academic Leadership program.
It's actually a VA-wide program, so I don't want to take any personal credit.
Okay, so this is a VA-wide program, but it's heavily adapted by our Harborand team. She's virtually in every single college campus, directly in contact with the veterans who are taking the GI Bill. Those are our young veterans, one of which is, you know, it's in medical school, not college campus anymore, but Eric is also used to be one of them. So she's doing an unbelievable job. We were last week, I think it was last week, in Queens College campus. We had the veterans counselor. Every college has veterans counselors, and we had the veterans counselors as well as our mobile van with Lynn together and Margarita, my nurse practitioner, my PharmD, Jessica from Manhattan campus, and it's a joint team. And Eric joined us also. Whenever he has time, he tries to join us, and he gets more veterans into our hands with that special language that the veterans speak to each other. And it has been incredibly effective. You know, we reached out to at least 14, 15 young vets. 4 of them are just signed up very recent, just new sign-ups. And we screened another 10 of them for Hep C, HIV also. So these smaller, very, very personalized efforts, I think, are key. So we have a presence in every campus, and we are really trying to change the cultural competency and the whole look towards the young vets.
Okay. Very good. Do you have any special programs for female veterans?
We have, as we've alluded to, an increasing number of women veterans that we see. So in mental health, we're certainly aware of that and developing programs for women. We have women's groups in PTSD and in other aspects of specialized treatment in the clinic. One area in particular, by no means unique to women, but it affects men as well, but certainly a critical issue, is military sexual trauma. We have, that goes by the abbreviation MST. We have MST coordinators at both campuses. We do active screening for MST, again, recognizing that certainly happens to men as well as women, but this is a very critical issue for women. We recently had an event, we have it every year, to better recognize, well, it serves several purposes, to increase awareness about MST and allow victims of MST the opportunity to express themselves, where they will write their message on a T-shirt, and then the T-shirts are displayed in the facility. So it's another area of priority for us, and particularly opportunity to address a concern for women.
And wear denim day.
And wear denim
Dr.
day.
Aytaman went to work in jeans, the first time really in my life, to show support to them. We all were wearing denims. For me, as the GI doctor running an endoscopy unit, MST is incredibly important. Our team gets yearly special training for MST because any scope through any orifice, whether it's through the mouth, through the rectum, can trigger MST symptoms. So we in endoscopy are especially sensitive to it. If a veteran is diagnosed with MST, we have a special check in our schedule, and also we specifically ask for it, but sometimes even the patient might not know, and the endoscopy might trigger endoscopy, and it gets uncovered by our psychology, psychiatry team, which also can happen. It happened to me 2 months after we did the endoscopy. Patient was diagnosed by one of our psychologists as having the MST symptoms triggered by endoscopy, first time. So it's pretty important, and we definitely have heightened awareness for it.
The other one that I would ask about is specifically for LBGT or VT, any programs like that?
We have a number of programs in both of our clinics in New York and Brooklyn. Again, groups specifically to address those issues for members of those communities, and it's something that I think there, again, is a heightened awareness and active programming for. It's not unusual to walk through the corridors and see the rainbow flags of staff that are trying to promote programs, and it's certainly an active part of our treatment programs now.
Does the New York Harbor offer any psychological care or help for cancer patients, or?
Oh, that's one of my favorite areas. As you know, we just launched the National VA Liver Cancer Team in January, and support to the not only the patient but caregiver is very high up on our list. And as Dr. Wolkin mentioned, we created this close relationship for Hep C treatments with both of our campuses' mental health teams. We have emails going back and forth constantly. Can I treat this patient? Could you take a look at him? He's using drugs. Can he comply with medications? In addition to that, we are working with our oncology, palliative, psychosocial teams together, and we have caregiver support groups, patient cancer support groups for different cancers also, if it's very relevant. So that's a huge part of what we do. Actually, we just embarked to a part of a national study where we will be looking at palliative and supportive care to the cancer patients. 7 VA, 7 non-VA sites got a huge award of $14 million for research to look at palliative care delivered by either liver doctors or cancer doctors, heavily into psychosocial support of the patients. Dr. Wolkin?
I would just expand on the emphasis that is given to caregiver support. They may not be veterans, but the caregivers themselves are eligible for treatment or will be supported by the team, and certainly recognize the burden that's on caregivers, that without the caregiver being able to be effective, that's not going to bode well for the person whom they're providing care for. So we're there to support the person who's providing the support.
The other one that I see is coming that's not really talked about yet is we have a number of aging veterans and a number of them that need care, and the difficulty is pretty much there's not a lot of in-home care or items like that. Is there any programs like that coming about or happening? Because I have 2 veterans that right now that are in nursing homes because they can't take care of themselves anymore. One, his wife just had a heart attack and she can't take care of him anymore. And I'm seeing more and more of this type of issue. And again, I see maybe part of the reason that she had the heart attack was trying to take care of him. I don't know. But it's a very difficult subject. We're all getting older, and end-of-life type of treatment is becoming a bigger thing. So what type of programs do you have out there for both, again, the patients and the caregivers?
Well, that's the reason why I said palliative care. Yeah. We are now, in the past, when you say to a patient, I'm going to put you to palliative care, or I want you to see palliative care, they immediately thought they are dying. That's not the way we look at it. Palliative care is now expanding vastly, and it's actually psychosocial support from day one, once we diagnose a patient not only with cancer, but with chronic illness. Yes. This is where palliative care comes in. We are expanding, and we are hoping to cover all those. And Dr. Wolkin also has just launched a multi-million-dollar tele-mental health program.
So to follow up on that, I was going to mention 2 things. First, we do have a home-based primary care program, so there are home visits by staff, including mental health staff, to see patients who are unable to get to the facility. But as Dr. Aytaman alluded to, there's within the last few years been really increased recognition of the role that telehealth can play, whereby through various media we can contact a patient or veteran in their home, particularly in the case of a geriatric patient, in the case of a student at their dorm, let's say, and provide care. In my area, it's telemental health care, but there's the initiative is more broad in terms of different types of telehealth care in general. As Dr. Aytaman alluded to, we were recently funded through VA in their Office of Rural Health to become what's called a telemental health hub. So we are now, we built a team of approximately 12 psychologists and psychiatrists. We're providing telemental health care, including a range of psychotherapies and counseling, as well as psychiatric medication, to 28 sites around the country, as far away as Texas, Iowa, and Minnesota, certainly as well as in our backyard, to veterans in our own facility who may have difficulty coming into the facility, as well as elsewhere in our network in New York State.
One program I know that we have here on Staten Island is we do have basically daycare for the older veterans, and they've tried to bring all of these services together, and several days a week they can go, they get brought to the facility so that if they have mobility issues they can get there. They have both physical and mental therapies type programs there, and it's a very effective program. I've seen some improvements in the veterans that have gone to those, and they're with other veterans, which again is an important item, I think, in that bonding between them.
This is excellent feedback for us. We have had the telehealth for a long time between Staten Island and the main hub, Brooklyn and Manhattan, St. Albans facility. We are all connected, and a lot of veterans who don't want to cross the bridge, which is not that cheap, you know, can come
Only have to
over
pay
here.
coming back.
Exactly. They can come here, and we can talk to them via the telehealth equipment. We are using this all across the VISN, and we created this VISN-wide network. I see patients for difficult liver problems from Albany, from close to Atlantic City, you know, all across the spectrum, and we can help them with their care. We are now moving forward, and I have to admit we are just doing it, giving our veterans small iPads that they can take home with, teaching them how to use it.
You have to have your grandchildren show you how to use it.
Exactly. I have to be shown by Eric also,
Yes.
and teaching them how to use it and being able to follow them at home for their chronic diseases.
Yep.
To cut down on the travel and everything. Of course, this is a great medium for our younger veterans who are better than us.
Oh,
They
yes,
might tell
absolutely.
us, Dr. Aytaman, click that, click this while we are together. So, but we are getting more into the 21st century. We are now adapting an app that's called the Annie app. You download it into your cell phone, and it reminds you, text messages, Ed, your medication is due, blood pressure pill is due. It gives you those kind of alerts, and we are trying to incorporate all these things, teach our veterans and ourselves, and use all these technologies in the VA.
That's a great thing. Are there any alternative treatments for PTSD?
There are alternative treatments in general that are effective across a range of mental health disorders, and we are trying to implement those. VA in general has been promoting the concept of whole health, a broader approach to wellness of the entire person, whether it's in terms of quality of life issues that are of importance to them in where they want to be going in their with their life goals, as well as their particular physical health. Specifically, what we have found that's particularly relevant in PTSD, we offer yoga, Tai Chi, there's animal therapy, we have a number of mindfulness type programs, typically transcendental meditation or other type of mindfulness programs have been very popular programs, and we call it complementary alternative medicine, really serve to complement more standard modalities, and taken together, again, give a wider approach to a person's quest for wellness.
Have there been any research to show that things like hyperbaric treatment or things like that have any effect?
Hyperbaric, the evidence for hyperbaric has been equivocal, as it has been for several others, but that's not to paint a negative brush about all complementary alternative medicine. There's very strong evidence about the palliative and efficacious results of just being with animals in terms of lowering blood pressure. Evidence-based for increasingly for mindfulness therapy. So
Except for camels. You don't want to be around camels. They're nasty.
equine therapy is very popular in parts of the country as well. I don't know about camels.
They spit and they bite, believe me.
Okay.
Starting with Eric, we kind of getting close to where we have to wrap up right now, but you have any thoughts or anything you want to give out to the viewing audience, the veteran that's watching, his family?
Yeah, just thanks for watching the show. It's been nice to be together, and it's just always good, you know, something obviously with the two people I mentioned, but, you know, try to check in with your old buddies and see how they're doing.
Yeah. Dr. Wolkin, I'm sorry.
So we have talked about reaching out to young folks, and clearly their life is very much centered around social media. So VA and VA healthcare has an increased presence on social media. There are indeed a number of apps. PTSD app is very useful. So we would encourage young veterans to, if not directly engage with the VA, to be online, look at what's available. It may not necessarily require being at a VA, but having access to some of those tools, and of course, most critically, it's a buddy system, so things that you can be aware of that as a buddy you can intervene with, and again, even having a Narcan kit, something to that effect, and of always having awareness of the Veterans Crisis Line as the lifeline
Very
for
good
help.
point, yes. Dr. Aytaman, any closing thoughts?
Thank you so much for having us here. Even if just one veteran thinks, oh, I should look at that, or I should come, and we can make a difference, it's all worth it. Please come, please talk, get checked. If you don't like this doctor, go find another one. VA system is not any different than the private industry. Find the one that speaks to your heart and be part of that, but most importantly, get checked.
Yes.
Paul?
Absolutely. You need to be involved. You need to go to the VA. Remember that they're much more likely to be able to help you than a civilian doctor, because they've seen much more of the type of injuries that our veterans today have. So go to the VA. You have to go there. They can't come and drag you in. I do think that there needs to be a screening for people getting off active duty. I think it needs to be forced.
Absolutely.
I've said this to our politicians, and I will continue to say it, but you have to make the step now and go to the VA and get the help that you need, even if you don't think you need it.
Well, this is Ed Salek, and my closing thought is we're here to bring you help. We're here to bring you, your family, your friends, if you have friends that are veterans, get them help to give you every possible outlet. Now, in all of the other shows, we talk about educational benefits. We talk about all the types of benefits that you can get through the organizations, and the camaraderie of being with a veteran that you can relate to. And this is no different. We're talking about your life, and you can make your life better. Your quality of life will improve by 100%. And the one thought I want to put out there is, over the years, the VA has taken a terrible beating in the media. And let me tell you something. From what I see with the VA, the greatest thing that you can do is go to the VA and get help, because they are light years ahead of some of the other medical programs that we have to compete with. You just keep watching in honor of, and we love you for watching it, and we will continue to bring you programs like this. Thank you very much.